Oh, hello everyone. So we have a case here, a 72-year-old male who presents to OPD with progressive dysphagia to solids for 2 months with no difficulty in consuming semi-solids and liquids. So he also reports generalized weakness for 1 month. A local practitioner ordered the investigation shown above. So what is the name of this investigation and what are the findings? What is the grade of dysphagia in this patient? What is your provisional diagnosis? And what investigation would you like to recommend for this patient? First question is, what is the name of this investigation? What are the findings? So this investigation is barium swallow study. So findings we have, so summarize, we have narrowing of esophageal lumen with shouldering and tapering of the barium column. So it can be called apple core appearance. So it is suggestive of an obstructive lesion. So there is delayed emptying and proximal esophageal dilation also. So the lesion is located most likely in mid to lower esophagus. One more thing, we should know the anatomical landmarks on barium swallow. So cervical esophagus, so that is from cricoid cartilage. So that is at the level of C6. So up till the thoracic inlet, that is T1 to T2. Then upper third of the thoracic esophagus, that is from thoracic inlet to around T4, and then mid esophagus, that is from T4 to T7. So that is the level of carina and lower border of azygous vein. Then lower esophagus, that is below T7 down to the GE junction, that is T10 to T11. It is just above the diaphragm. So looking the frontal view, the narrowing is at the level where the tracheal shadow and the main bronchus bifurcation, that is carina, it seems close. The lesion is just around or below that. Okay. In lateral views, the narrowing is well above the diaphragm and it is not at the cardioesophageal junction. Then the contrast column abruptly stops at the point higher than where the diaphragm contour appears, suggesting that this is not a distal esophagus. The lower esophagus beyond the narrowing is partially visible and it seems patent, indicating the lesion is in proximal to lower third. Okay, fine. The involvement corresponds roughly to carinal level or just below it, which aligns with the mid esophagus. Fine. Then second question we have, what is the grade of dysphagia in this patient? So as per the dysphagia grading system, we know grade 1 is difficulty with solids food only, grade 2 is difficulty with solid and semi-solid food, grade 3 is difficulty with liquid as well, and grade 4 is complete dysphagia. Fine. So in this patient, the patient is able to swallow liquids and semi-solids but not solids completely. So most likely we are dealing with grade 1 to grade 2 dysphagia. Fine. So what is your provisional diagnosis here? So keeping in view the history and the radiology, so most likely it is carcinoma esophagus. So most likely carcinoma, squamous cell carcinoma or adenocarcinoma involving the middle to lower esophagus. Okay. Now what further investigation would you recommend for this patient? So first we will go for upper GI endoscopy, that is esophagogastroduodenoscopy with biopsy for histopathological confirmation. Second is we can go for contrast CT of thorax and abdomen for staging and evaluation of local spread and distant metastasis. So we can also go for endoscopic ultrasound for assessment of depth of invasion and regional lymph nodes. Okay, so this is optional if it is early disease. Then we can also go for PET scan if the metastatic disease is suspected, and besides we have to go for routine blood work, that is complete blood count, hemogram, renal and liver function test, and nutritional assessment. Okay, so besides, as it is at the level of carina, so to rule out any infiltration into the carina, that is trachea and bronchus, so we can also go for bronchoscopy here. Okay.